In this lecture, we are going to start our study of the GI tract organs. So remember that the alimentary canal, or GI tract, is going to be a continuous tube, and that food will travel through that tube, being processed, broken down, nutrients extracted and absorbed, and whatever is not absorbed will ultimately leave as feces. When we look at the tube, it all starts up here in the oral cavity. So when you eat food, obviously we have our mouth, which is technically your oral cavity or even buccal cavity. And remember that the mouth is where it all begins, and the mouth is lined with that stratified squamous epithelial tissue. Again, you want to have multiple layers. Think of everything that you're chewing and eating. So you would want many, many layers for protection. Now, because it has many layers, it wouldn't be really good for absorption. So there's a little area, this is the tongue. Underneath your tongue, the epithelial tissue is actually pretty thin and very vascular. And so that's why sometimes you might have a sublingual medication that you take. And sublingual just means that you put it under the tongue in that area for absorption. Had a little battle with the pen. So sublingual. So, sometimes if someone is hypoglycemic, there's a sublingual, I think it's some sort of like paste they can put under there. We talked about nitric oxide, NO, when someone's having ischemia or angina, right? They're having issues with heart. Vasoconstriction, you take the nitrostat sublingual. So it's a good place for quick drug absorption into your bloodstream. The vestibule is the little space between your teeth and your lips. So I always say that's where you would put your chew. So a little space there. And we know that the mouth does both mechanical and chemical digestion. So mechanical is pretty obvious. You use your teeth, you pulverize your food, you chew it, you mix it with saliva and use your tongue. So what we swallow is not basically what went in our mouth. And then chemical digestion, remember, is using enzymes to break chemical bonds. Now your mouth, there's a little bit of carbohydrate digestion that starts here and a little bit of lipid, but not a lot. It just starts the process because, when you chew your food, depending on how thoroughly you chew it, it's not always in your mouth for a really long time. We do have our palate. We have our hard palate, which remember is from the maxilla or maxillary bone. And then we have our soft palate, which the main piece of that is going to be the uvula. So when we look at teeth, obviously teeth are for mastication, chewing, breaking down our food, mechanical digestion. The occlusal surface is kind of like the bite surface when you bite down. And you've probably heard of deciduous teeth versus permanent teeth. So deciduous teeth are called baby teeth, and there's about 20 of those, whereas permanent teeth are called adult teeth, and we have about 32 of those. So baby teeth come in at different times and most are lost as well. I always like to point out the number of deciduous teeth because if you're going to do the whole tooth fairy thing, keep in mind you got 20 payouts. I like this image because it actually shows you the deciduous teeth, right? The baby teeth and then the adult teeth. So those adult teeth are developing up in the maxilla and the mandible. And what happens is as they develop, they're going to actually push. And that's what pushes the baby tooth out. So as those teeth get loosened, as the jaw grows and there's more room for the adult teeth to erupt. And that's a little bit of how that happens. Now, if we look at teeth, we do need to know some classification of teeth. So in this picture, you see top and bottom jaw, right? Mandible and maxilla. In your notes, I just put the mandible because it's easier to just label it one time. So you're going to have incisors. So I'm just going to number 1, 2, 3, 4. We have 4 incisors. So this is per jaw. So when I'm done, you would multiply everything by 2 if you want to know how many in the whole mouth. When we look at incisors, the 2 in the middle are your central incisors, and then the 2 on the sides are called lateral. Now on either side of those, you're going to have your canine. So, sometimes they call the canine the Dracula teeth, right? These are a little more sharper. They can be called canines or cuspids, one on either side. These are like the fangs, and these are really good for piercing meat. Incisors, by the way, are really good for biting into things. Think about when you bite into an apple. And then we have what are called our premolar or bicuspid. You can call them either one. Don't worry about the age. This is roughly, when we're looking at when these teeth are coming in, but that varies for different people. So we have 2 on either side. So I'll put a little, I call them bicuspids. So I'll put a little B there and here. And again, you can call them bicuspid or premolar. And then we have our molars. And I have 4 plus 2 because the 2 in the back are the wisdom teeth. You can see on the upper jaw. So we always should have 2 of these molars. Now, the third one you may or may not have. So it's typically, there's a total of 4 wisdom teeth. So that's why I have 4 plus 2. But you might have been born without any wisdom teeth or 1. That varies. And basically, we have these removed because, you know, our skull, our jaw just isn't big enough for these molars to fit anymore. And so they're removed because there's no space for them. And our bicuspid and our molars are really good at like crushing and grinding food. So if we look at a tooth, every tooth is covered in enamel. So enamel is the hardest substance in the body. It's harder than bone. And that's what we worry about when we brush our teeth. We don't want to wear away at the enamel. The crown is the visible portion. So that's where all the enamel is. The root goes into the bone. And it's anchored with stuff called cementum, which sounds like cement. It's basically a very sticky protein that holds your tooth in place. Now, this blue stuff here is called dentin. That's the bulk of your tooth, and it's very similar to bone. But as you probably know, inside your tooth, you do have blood vessels and nerve supply. If you've ever had dental work, you're well aware of the nerves. Maybe you have sensitive teeth, so if you drink something really hot or something cold, you feel that it hurts a little bit. So that's a pulp cavity, and that's where the blood vessels and the nerves are. So when they do a root canal, it actually goes up through this root. That's the canal, literally. They go in and they kind of strip all that out because there's damage. And then the gingiva is just the gum. So when we look inside the mouth, we know we've got the tongue, and it's actually skeletal muscle, has some stratified squamous epithelial. Now the tongue is literally anchored by this little thing here called the lingual frenulum. So sometimes it's a little too tight. That's where the expression tongue-tied came from. If it's too tight, then you can't move your tongue and you would have problem with speech. So sometimes they can snip it so that there's more space there. Your tongue has taste buds. It has mucus glands, serous glands, and it does make an enzyme called lingual lipase. So when you look at this enzyme and you see lipase, that tells you it's going to start to break down lipids. Not a lot of lipid digestion, but it can start here. When we eat and we mix food and we chew it and mix it with saliva, we form what's called a bolus. So a bolus is what you actually swallow. And if you have kids, you've seen a bolus when they spit their food out back at you. And then papillae, remember, are these like rounded or nipple-like projections on the tongue. And the papillae are going to have a lot of those taste buds. Saliva is very important. When we look at what is actually, in saliva, it's going to help clean our mouths, but it's actually made by 3 different glands. Now, you don't have to memorize how much is produced a day, but the 3 glands are called the parotid. So, and you have rights and lefts of these. Usually on the models, you only see one or the other. The parotid's right out here by, it's anterior to your ear. It's near the masseter muscle. This is a pretty major salivary gland. This is the one that, if you've ever heard of the viral infection mumps, that virus gets inside the parotid gland and it can be swollen and very, very painful. Submandibular is right under the angle of your jaw. And then sublingual are going to be underneath your tongue. Now remember, these are exocrine glands. So they're going to have a duct, right? They're going to secrete through a little duct. And in fact, the submandibular ducts, you can see them. They're on either side of your lingual frenulum. So if you go look in a mirror, look underneath your tongue, find the lingual frenulum on either side is the opening to your submandibular ducts. And if you close your mouth and you kind of push on those ducts, but keep your mouth closed, you might squirt some saliva. You'll feel it be ejected into your mouth. So saliva is a lot of water, mostly water. Does have some other stuff. It has some electrolytes in it. There's a little bit of sodium in it and chloride. It does have mucin. So mucin is a protein, and mucin, when you add water, becomes mucus. So you might notice if you are dehydrated, your saliva gets really thick. because there's less water in it and there's more mucin. So when you have a dry mouth, you will notice that. It does have some protection. It has IgA, immunoglobulin A, and it has lysozyme. So these are things that help protect, right? They're part of our body's defense. There's a whole bunch of other things in here. We're not memorizing everything, but just know some of the components that you would see in saliva. It even has a little bit of bicarb to help buffer. So why do we have it? Well, as we mentioned, lubrication, binding, that saliva is important, helps form the bolus. We also need it to lubricate for speech. It's very difficult to talk if your mouth is really dry, so it forms a coating and lubricates. We have to have it for taste. Food, when we eat, chemicals dissolve in saliva, and that's what activates those taste buds. Really important for oral hygiene. So we mentioned lysozyme, antibodies. It also flushes and washes your mouth out. So having healthy teeth is to have more saliva. So at nighttime, we decrease our production of saliva. And you might notice when you wake up that your mouth is drier. If you sleep with your mouth open, you might have a lot of saliva on your pillow. And so in the morning, we know that morning breath is not so fresh. And part of that is because all the bacteria have replicated at night when we have less saliva. And when you see those ads that tell you to chew sugarless gum, that it keeps your mouth cleaner, it's kind of true. The only reason is that sugarless gum, right? You don't want the sugar on your mouth because of the bacteria, but sugarless gum is going to produce more saliva, and the more saliva we have, the healthier and cleaner our mouths will be. And it has enzymes. We said that the tongue makes the lingual lipase, but in saliva is an enzyme called salivary amylase. And so salivary tells you it comes from the saliva, and that starts to break down starch. It also does have some buffers, so it can help neutralize some of the acids in our foods. So what controls our salivation? It's our autonomic nervous system. I put this picture in because I really thought it was a nice overview. You can quickly review the actions of the sympathetic at the various organs in the body versus the parasympathetic. So saliva is triggered by the parasympathetic when we're relaxed, right? When we also, we'll talk later, but when we like see food and think about food or eat food, all of that increases saliva, whereas the sympathetic is going to slow it down and dry it up. So if you've ever had to maybe talk in front of a large number of people and you get nervous and your fight or flight kicks in, you get a really dry mouth, which doesn't help you because it makes it even harder to talk. Now, once we chew the food, we mix it and form a bolus. We're going to basically kick it back here to our uvula, and it goes into our oropharynx. From our oropharynx, the food just goes down in the laryngopharynx. Now, there is a connection here. You notice it could go out the nasopharynx. We don't want it to, but it could come out your nose. I don't know if you've ever, childhood memories. I remember elementary school sitting at the lunch table and Carl Bickford laughing so hard that milk shot out of his nose, and it was so disgusting. But I probably shouldn't have said his name, but it can come out of your nose, but it's not supposed to. It's supposed to go down the oropharynx into the laryngo. And remember that the food has to cross over to the back, whereas the air comes in our nose and that has to cross over to the front. And that's why it was so important that we had that epiglottis there to make sure the food is going to go down the laryngopharynx into the esophagus. So the food now is going to enter the esophagus. And if we were to look at the esophagus, you can see it has all 4 layers we already looked at. You have a lot of stratified squamous epithelial. Again, protection. Think about if you've ever eaten like a big pretzel, right? Or you feel it scraping your esophagus all the way down. So we have a couple sphincters there. Remember that they're going to be smooth muscle and they control the movement of food. There's an upper esophageal sphincter, and then there's a lower esophageal sphincter. A lot of times the lower one is just called the cardiac sphincter because remember your heart is over here. So 2 sphincters that open to allow the food to come through or close to prevent it. There is something called the esophageal hiatus. So if you look at the anatomy, here's the diaphragm. Notice that the esophagus has to go through the diaphragm to get to the stomach because the stomach, is inferior to the diaphragm. Well, in some people, they actually have a big opening in their esophagus. So their stomach actually protrudes above. This is all stomach here. Now, the reason that's not good is the stomach has a lot of hydrochloric acid. And we know that the pH of the stomach is very low, like around 2. So the diaphragm actually helps close off this cardiac sphincter. And so it helps prevent hydrochloric acid from going up into the esophagus. Well, if you have a hiatal hernia, you have this bigger opening, right? It's basically an anatomical issue where now it's too big and the stomach sticks up. The stomach protrudes above the diaphragm. Well, there's your stomach acid. So now you don't have the diaphragm kind of like pinching it off. So you're more likely to get this acid reflux and get this stomach acid up into your esophagus. Now, when we look at this, by the way, this is called GERD. And you've probably heard of this before. So let me write this here, gastroesophageal reflux disease or heartburn. And we're going to talk more about this disease when we get to the stomach and how it's treated. But a hiatal hernia, this individual is going to suffer from that and they're going to be on medication. Now, I believe this can be repaired surgically because you can get an esophageal ulcer. You can get an ulcer in your esophagus, which would not be good. And then lastly, as far as swallowing goes, it has 2 components. There's a voluntary and involuntary piece. So, as you're chewing your food, there's a reflex. You chew the food, you form the bolus, and the tongue is used. So when you eat, think about it, the tongue pushes the bolus back. When the bolus hits the uvula, that's what triggers the swallowing reflex. Now, the uvula also triggers your gag reflex. So if you're ever taken too big of a bite of food and it hits it, it might make you gag or even vomit. And so the information hits the uvula. It's a reflex. We're not going through the whole pathway. Just know it also involves the medulla so that the food can be pushed down into the oral pharynx, and then peristalsis moves it down. What I'd like you to understand is that this is a reflex. It does involve the brain and the tongue and the uvula, and there is some coordination to it. And so sometimes if you have maybe a patient is on like an NG tube where they're not eating food with their mouth, they have to relearn how to swallow food. Or if you have a stroke patient, they might have difficulty swallowing food as well with this reflex, because remember, once the peristalsis kicks in, then that epiglottis is also triggered to close off. So if you have a patient who has issues with the swallowing reflex, usually stroke or some sort of dementia, then what happens is you're going to worry about them choking, and they might not be allowed to eat a lot of solid food because you're worried about that choking hazard. So this wraps up the first part of our GI tract organs, where we go through the mouth, the pharynx, and the esophagus.